So now, without further ado, it is my pleasure to introduce today's first speaker, Alexis Anderson, a principal with the Ipsos Healthcare Advisory Team. Alexis, you have the floor.
All right, thank you, Ellen, so much. Appreciate it. And first and foremost, just really want to thank everyone who's attended this webinar today. We're so excited to talk to you about this topic of TECHQUITY. And we've got a great session lined up for today. So if we want to take a look at the agenda, I'll walk you through what we'd like to accomplish. And so first things first, I know some of you are coming to us having spent the majority of your careers focused on TECHQUITY. You're experts at this stage, and you're here to learn from our esteemed panel members, their input and their opinions on TECHQUITY. Others, you're joining us completely new and you're wondering, what is TECHQUITY? And so you're here to learn a little bit more. And so we welcome all of you to today's event. For that reason, I'll kick things off for the first few minutes to introduce what TECHQUITY is, why it's important, and what we think makes for a strong TECHQUITY strategy and the things that need to be considered. Next, my colleague Ellie will introduce an ethnography video, which we conducted in partnership with the Health Foundation. And that personalizes this experience of TECHQUITY and puts at the forefront the experiences of people in our communities. And then for the remaining time, I'm so excited to have this panel discussion where we'll be able to learn from our experts on what the industry should be doing and how we need to be moving forward. And so if we go to the next slide here. Here are our panel members. You see them here on video, and so we're excited to have this wonderful group of experts, as I mentioned. And as we transition to the panel discussion, you'll have an opportunity to hear from them on their full background and their introductions. But in the interest of time, we'll jump right into TECHQUITY. And so we know that the healthcare landscape is changing in so many ways, but one of those key features, if we go here to the next slide, is this integration of technology into the healthcare system. And so, now more than ever, let's take a look at how technology's been integrated into the system. So we know that in the last few years, particularly with COVID, we're seeing telehealth, mobile health apps, connected health devices, wearables, patient portals. These have been slowly trickling into the healthcare system for years, but in recent years, it's become increasingly more important. And if we transition to the next slide here, I think in my own mind, as I think about technology and the healthcare system, it's a wonderful thing. We can and we should continue to make the healthcare system more efficient through the use of technology. And of course, Ellie, if you want to show them some of the other benefits from this integration of technology, we now have these new tools and methods of innovation that enable us to increase patient outcomes, enhance patient safety, as I mentioned, make the system more efficient and effective. But at the same time, and the reason why we're here today for this TECHQUITY webinar, is we have to acknowledge that the healthcare system, barreling down the tracks and having the train move towards this completely tech integrated world doesn't work for everyone. And so we have to acknowledge the fact that if we're not designing and implementing healthcare technology in a way that works for everyone in our communities, we're in fact creating this divide. We're making it hard for folks to access the healthcare system if they need to use technology to do so. And so TECHQUITY is this term that causes us to pause and say, are we enabling everyone to be able to use the healthcare system, or is technology creating that barrier and worsening the digital divide? And so if we go to the next slide here, and I want to underscore the fact that this just isn't something that's focused in on healthcare. And so technology is now this super determinant of health. Your ability to access and use technology doesn't just extend to the healthcare system and your ability to engage with your physicians, your providers, the healthcare system itself. It's so much larger than that. So particularly, during COVID, we saw that use of technology enabled people to connect to education, their lived environments, employment, transportation, so much more. And so with that lens in mind, technology is that super determinant of health now. And so it really underscores the importance even further of why TECHQUITY is something that the industry needs to focus on. So we'll go to this next, and I'll walk you through what we've done in partnership with the Health Foundation and what we have upcoming, and we'll kind of discuss TECHQUITY a little bit more in depth. So we did 3 things with the Health Foundation. The first was industry expert interviews to get their input and opinions on what TECHQUITY was, what's been done in the industry to date, and where we need to go. Again, I'm so thrilled to have our panel members here today to provide that additional context there on this exact subject. Second, as I mentioned, we conducted patient-focused ethnography, so thrilled to be able to introduce you to my colleague Ellie, who will introduce that video to us. And last, we wanted to acknowledge that TECHQUITY has been a topic that's existed for many, many years. There's been groups out there who have been focused on this subject for 10 plus years at this point. So we wanted to conduct secondary research and integrate that into our findings to take into account all the wonderful work and insights that have been generated to date. And so there's 2 key resources available for you. First is the Path to TECHQUITY, which is available here in the webinar for you to download and review. The second is that ethnography video. All right, so let's get into, I keep using this term TECHQUITY, but what exactly is TECHQUITY? In our minds, it's the strategic design, development, and deployment of healthcare technology to advance health outcomes and advance health equity. And it encompasses that notion that I mentioned earlier, that healthcare technology can be supportive for individuals. It can enhance health outcomes, but it also has the potential to cause harm and diminish health prospects if it's not designed and implemented in that equitable, intentional, and inclusive manner. All right, so really quickly, 3 core elements or building blocks that I'd like you to keep in mind. The first is access, the second is initial use or uptake, and the third is sustained engagement. So first, access. Can someone get that mobile health app or that phone in their hands, for example? Do they have the right Wi-Fi, broadband, internet, et cetera, to be able to even use something in the first place? Second, once you have that, it's initial uptake and use. Does that healthcare technology have the right acceptability and accommodations, for example, language settings, accessibility features to enable you to even try to use it? And the third is sustained engagement. And so someone can have access to healthcare technology. They might know how to work it a bit, but do they feel, know, believe that that healthcare technology is there to support them? And do they trust that it's doing what it says it's supposed to do? They feel comfortable sharing their data. If we don't have all 3 of those, we can't achieve TECHQUITY. And so here we go. Wrapping this up, I want to just convey that for this webinar today, we want to acknowledge that we have this joint responsibility to ensure that we move forward with TECHQUITY, and that's what we're here to do today. Last but not least, want to really quickly touch on 4 key pillars for the path forward, and our panel members will add more context here in a moment. We know we need collaboration, transparency, inclusivity, and that overall commitment to transformation. In terms of that commitment to transformation, I'm excited to share with you what Ipsos and the Health Foundation are doing in terms of Next Steps, which is an industry benchmarking initiative. So we're going to be measuring where the industry is at with TECHQUITY and establishing tangible milestones, next steps, and a roadmap, which we're excited to launch towards the end of this year and beginning of next year. So if you'd like to get involved, please don't hesitate to reach out to myself, and you'll find my email right here. And I think with that, I can hand it over to Ellie.
Great, thank you. So when we're doing research, and especially when we're doing research around issues of inequality and inequities, it's so important to us that we include the perspectives of the patients themselves, because obviously without hearing from the end users, we risk not seeing the full picture and not understanding the nuances around this issue. And I think we could draw a parallel to the vaccine space. We know that it's not enough that we make vaccines widely available and we say to the public, vaccines save lives, because there are more complex demand side challenges to address, like trust in companies and governments and social norms around vaccinations. And so it is with TECHQUITY. So to help us understand what TECHQUITY looks like on the ground, so to speak, we reached out to a small number of people across the US who all experience different barriers to health-related technology, barriers accessing the internet, using technology, understanding the language, and these more intangible challenges too, like trusting companies with their medical data and seeing, the point in technology, like how does this benefit me? We asked them to show us, in the context of their everyday lives, what health tech they're using and what is it that's holding them back. And using this ethnography method, they filmed themselves using their cell phones and they sent us this video footage back to give us a window into their world. So here follows a 5-minute video which we edited together from this footage to bring to life the issue of TECHQUITY. So bear with me now while I just switch my screen. And away we go.
Yeah.
Now we're recording.
Oops.
You're losing.
It's the knuckles.
How tech savvy would you say you are, Dad?
He's a little.
Okay.
I was playing a game and the cat sat on the keyboard and it blew everything all up really big and I couldn't figure out how to get it to go back down.
My name is Hudson. I live in the United States, in the state of Michigan. I'm married, I have kids. Because I'm a truck driver, I spent like 5 years working for my city community school. And usually every morning, just wake up, take my car and drive, go work and go shop, you know.
I live here in western North Carolina in the Smoky Mountains with my wife and my cat. The area has actually gotten a little bit popular because of the pandemic. A lot of city folks have moved out here to realize that the internet does not work very well. We do have internet via a satellite. If we do need to use the internet for anything, we usually have to go to town. It is a challenge.
You want me to try?
Yeah. When I had my eye infection, I was paying for all my medication. They wanted $100 to see me. And
We drove 2.5 hours just to see the doctor, and we didn't have the $100 because we spent 80 of that just getting gas. And
I was incarcerated in 1998 at the age of 18 years old.
As you can see, I was a fresh-faced baby.
You know, when I got out, I was given an iPhone and I didn't really know how to use it. So I had my 14-year-old niece kind of show me the way. You know, later on down the road when I had problems with, you know, medical issues or things to that nature, I was able to look things up on the internet prior to going to a doctor. I didn't have health insurance, so I couldn't just go see a doctor for anything that I wanted. So when I would go on places like Google, look for like community health centers, places where I could go cheap.
Would benefit greatly if we were able to go ahead and contact our doctors and deal with our insurance company.
but they use a lot of times your social security number and your driver's license number as a way to identify you. And when hackers break into different things, they can get that information.
Went and got a COVID test. You know, this is the era of COVID. And they gave me like a website that I would have to log into.
But I just felt that it was kind of, you know, creepy that all this other stuff is on here that I don't know about. And I was kind of like, hey, I don't even remember any doctor telling me that.
So you sign in, you have to log in, and then you're having difficulties because you can't read this stuff, or you're not understanding, you're thinking you're looking for your, you know, x-rays, and we call them x-rays. Now they call them radiology. I've just tried to stay away from dealing with that part of it. I'd rather talk to the person. I'd rather have the paper sitting in front of me.
I do not have any health applications on my phone because I feel that if my phone were to be compromised, so will my health information.
My whole wife, she has a barrier with language sometimes. She doesn't use it a lot. I'm the one who uses it, make an appointment to schedule everything. I don't do like the videos, meeting with doctors, not yet. It's better for me because you might be answering things behind the screen, but it's different than being in front of someone.
We've lost the contact, we've lost the interactions with a human being. With that being said, I feel that technology throughout the years have changed and have improved our way of living.
We definitely are missing out on a lot of stuff, and also our ability to just operate as a 21st century individual, considering that technology is so imperative to everything that we do now.
Right, and I just unmuted myself. Thank you so much, Ellie, for sharing that video with us. I know I'm so excited to hear the panel members' reactions to that. And if we go to the next slide here, I think we are actually ready to transition into the best part of today's webinar, which is the input from our wonderful panel members who we're so grateful to have on board. And so we have Dr. Pierre Vigil, we have Sarah Scholey, and we also have Dr. Chris Gibbs. And so I would love to, we'll kind of pivot away from the slides here. Everyone will get this copy on Monday of everyone's bio with a link to the recording as well. But maybe Pierre, I'd love to have you introduce yourself to us and talk to us about TECHQUITY, and we'll go around the room.
So good morning, afternoon, evening, wherever people are in the world. Pierre Vigil, I'm here in Philadelphia. It's a pleasure to be here, and thank you very much, Alexis, for the invitation, and Eleanor for the work that you've done in this space. I also need to thank Jana over at the Health Foundation for connecting all of us to do this. I am the VP for Population Health and Social Impact at Equity Health, and I also serve as the organization's executive director of the newly formed foundation, the Equity Foundation. Equity Health, just very, very quickly, is a Web3 company that considers itself to be very patient-centric. We're looking to improve health outcomes, and we do that by creating networks that are in healthcare and research. But because of the nature of the things that we're talking about, the networks that we're looking to create are very cross-sector in mind and in membership. And they leverage specifically two pieces of technology. One is blockchain or distributed ledger technology, and the other is artificial intelligence. And we use two of those in combination with this notion of networking or consortium as a service to release or make data more liquid and movable between different sectors so that people can actually gain greater insights from their engagement in different sectors and improve outcomes as a result of that data moving more fluidly. My background is clinically trained in emergency medicine, but spent a good amount of time in the public sector, including some time in the nonprofit in East Baltimore before going into government. I used to be the health commissioner in Washington, D.C. for a few years, and then was in government, in academia, for a while as the associate dean for practice at GW School of Public Health. So my career has sort of run the gamut from a little bit of time in the clinical space all the way through to time in community, a good amount of time in community, the time in academia, but always trying to connect these very disparate dots, including the need for us to be far more diligent about how people gain access to different services. And in this increasingly digital world that we're in, it is of paramount importance, even pre-pandemic, frankly, as we've been of paramount importance to recognize the role that technology and digital inclusivity play in everyone's daily life, not just with respect to health, but with respect to all of the things that impact health. Your ability to be educated, your ability to gain access to housing, training, any number of different things that we do as a result of technology, and the need for that to be, as has been articulated, accessible, affordable, useful, and long-term then capable of changing how we gain access to a number of different things that change our health and health outcomes just can't be understated. So TECHQUITY to me is not just a health imperative, it's actually a life imperative, because we have a need for that to be a space where everybody can gain access for a number of different things, with health being one of the outcomes that's improved.
Yeah, thank you so much, Pierre. And I love what you just said there on how it's a life imperative. Sarah, I'd love to have you introduce yourself next.
Thank you. And good morning, good afternoon to everyone. I really appreciate the opportunity to hear about this work and talk about it with you. I'm Sarah Hudson Scholey. I'm a vice president at the National Committee for Quality Assurance. And I've spent, greater part of 2 decades really trying to understand where there are disparities in care and ways that we could measure and evaluate healthcare organizations and really try to promote greater attention to equity. And at NCQA, we've made a commitment that high quality care has to be equitable. And so we're including equity in all of our programs and our measurement strategy. I think that's really important to think about technology because it has such a great opportunity to expand access to care, to allow people to have access to tools that will help them to manage their care better and to work more effectively, for a care team to work more effectively with individuals and to understand their needs. But this really needs to be intentional because it's a partnership in all of healthcare is a partnership that should be aimed towards meeting an individual where they are and understanding what matters to them. And as we think about how technology can make it easier for someone with diabetes to manage their blood glucose, then new technology like continuous glucose monitors can make that work better. But we have to think about, well, what does that mean for the individual and how well do those tools actually fit within their daily life, and how do they make it easy for them rather than another piece of learning and challenge for them in managing their care. And think about people with kidney disease and the opportunities for home dialysis, which really need to take into account not just people's preferences, fears, concerns, barriers, but also where they live and what's the capacity in their home environment for these kinds of tools and technology, and what sort of social support do they have. So I'm really excited about the work that we're doing at NCQA, where we've developed some accreditation programs for healthcare organizations that challenge organizations to think about how they understand their members or the people that they serve, and then also challenge them to work deliberately with the community-based organizations who can actually help to address social needs, and where the healthcare organizations are actually taking an active role in understanding social risk. And so I think technology really has a lot to play there in providing the information that's going to guide organizations, but with that lens that's focused on individuals and communities.
Wonderful. Yeah, thank you, Sarah, so much. I think you touched on some really great examples from your experiences, so appreciate that. And last but certainly not least, Chris, I'd love to have you introduce yourself as well, and then we'll get into some of the discussion, but over to you.
Sure. Thank you all for having me on this important webinar today. I'm Chris Gibbs. I'm originally trained as a physician in surgery and preventive medicine, and spent many years on the faculty at Johns Hopkins as the associate director of the Urban Health Institute there, 15 years doing that. And that institute was started primarily because of the realization that, like many academic medical centers, Johns Hopkins, the downtown campus, is located in the middle of an urban inner city area, which although Hopkins is credited as, fixing the health of many nations or many people around the world, things weren't so hot in their own backyard. And at the same time, it was really unrealistic to just expect that because a hospital or a health system is there, it would get better, or that the faculty would just give back on their spare time and that would make it better. So they started this institute and charged it specifically with working with the underserved populations, along with all of the clinical units at the university, to try to develop models of improving health of underserved populations and then exporting those to other areas. Because during this time, and this was a while ago, this was 20 years ago or more, and when I started that job, I said, well, I've been focused on these things for a while and studied these things for a while. I trained at Hopkins. I know what I'm not going to do. And that's what everybody else is doing because it ain't working. And I didn't know exactly what I was going to do that was going to be different. But to make a long story short, I decided at that time, this is more than 20 years ago, that I thought that there would be value in looking at technology as a way of addressing the term health disparities or inequalities wasn't even there yet. It was just minority health or community health at that time. And, you know, it was so, just to give you a reference of where this is not like now when most hospitals have technology. My boss, which is a physician, told me, he said, Chris, you're a bright young kid. You're going to do well here at Hopkins, but you got to let this technology thing go. It's not going anywhere in healthcare. Obviously, the world changed under his feet, and then all of a sudden I became the expert in the department in those early days on technology. But, you know, the only reason I say that is to give you a perspective that I didn't come into this game in the last 5, 10, or even 15 years. It's been longer than that. And two, I didn't come at it the way most of my colleagues have, either because EMRs were being pushed on you, or now in the coronavirus, telehealth, or remote patient monitoring. I came at it with a much broader perspective and didn't limit it to one technology or two technologies or just stuff in the hands of doctors. I had a very broad perspective, and so that's brought me to some very different places than where most of my colleagues are today, and that's fine. But just to help you understand how I got to those places, I gave you that background. So today, I run a digital health innovation and transformation company that I started about 12 years ago, and we build innovations for patients with a special emphasis on underserved populations, not just African American. We have had projects in African American, Hispanic, Latino, and also American Indian, Native Alaskan, and rural underserved Appalachian whites, and all kinds of populations. And we also work with health organizations, large and small, large health systems, small health systems, doctors' practice, to understand this world of technology, how to pivot and thrive in it. And from our perspective, the last thing I'll say, it's not really about just being more efficient and doing things better. It is about that. But we believe the power that technology has, and it has the power to enable us to do things that were impossible before, that we couldn't do, so that we can achieve things that we were not able to achieve things before. And that's going to mean a change of how we think and how we do things, and that's inevitable. That's happening now, even as we speak. And so that's what we do.
Love that. Thank you so much, Chris. And so to kick us off, I know we just watched that video together. I would love to hear from everyone, you know, why do you think TECHQUITY, we've touched on this a bit, but to hit it right on the nose, why is TECHQUITY important? What sticks out to you from that video is just something that you've seen from your careers. That was an example of why this is important and why we need to address TECHQUITY now. So maybe I'll start with Chris and we'll work our way backwards.
Okay. Well, yeah, absolutely. I mean, this is not new to any of us on this panel. These kind of issues have been there for a very long time, and we've been working in trying to do this. TECHQUITY is a new term, and that's fine. That's good. Anything that will draw people's attention to the issues. But I think it's important. I mean, we're not. I've always said that, you know, as you said in the intro, technology, we believe strongly, has the ability to help. Let's just be honest. The United States has been focused on healthcare disparities or inequalities as a national since about 1984, when the Public Health Service put that report on Black and minority health out. In Europe, they've been focused, in Britain particularly, they've been focused on it for much longer. But in Europe has introduced national level policies to try to address these issues, then came back 20 years later to measure the impact, then did it again. So they've done it twice now over 40, 50 years. Their experience is the same as our experience. No benefit, no improvement. Sometimes things get a little better, the next year they get worse. So, you know, we've been doing this for a while and it hasn't worked, but we've got to, we have the opportunity where technology can help us, I believe, help us accomplish some things. But if we don't do it right, we'll only make the disparities and the inequalities bigger, faster. So I totally agree.
Yeah. Sarah, what do you think to that? Or Pierre, weigh in.
Well, I think that's right. And I think we really need to be intentional as we think about where technology has a role and how do we use the technology in a way that it's actually serving the purposes that for all the stakeholders involved. I do a lot of work trying to understand how do we understand what people's preferences and goals are, and how does that information really shape the care plan? How does it shape how the care team works with individuals and how individuals manage their own health? And how do we use that information to say, are we making a difference? Are we actually achieving something important? Well, technology, I have to tell you, in a paper-based world, collecting data from individuals is just a non-starter. Using that information in clinical care, tracking over time, it's so hard. But technology can help us, but only if we're really intentional about it. It means that we have to think about the communication barriers of language, and not just is the language translated, are the tools translated into the right languages, but is it language that people understand? Are we using tools that overcome other kinds of communication barriers, like where the computer can speak the questions rather than requiring somebody to read them? And then also, how does that technology actually support, provide decision support to the care teams and longitudinal tracking over time? So there are many ways that these technology can really help people be more involved in their care and be on the same page with the care team about what they're trying to get out of it, if we're intentional in thinking about every step along the process and bringing individuals and communities into the same space of design and development as the care teams and the IT specialists.
Yeah, great point, Sarah. Thank you so much. Pierre, what are your thoughts on that?
So as I was watching the video, the first thing that struck me was the connectivity piece of things. The fact that child, the daughter who was talking to mom and dad, and in this instance they were talking about, it was an interview, but I'm sure that tool is used for them for her just to be able to check in on them, for her to be able to speak to them, for her to be able to connect with them. And the role that technology continues to play in our ability to connect. I mean, I remember carrying around a cell phone that was the size of a brick at one point, right? Weighing down my scrub pants, the old Motorola flip phone. And we thought we were doing something with a phone that was that massive. And what we've moved to now with respect to smartphones and what they have the capacity to do. But the connectivity piece of things, I think, is the big takeaway that I got. And it's not just connectivity with services, as we talk about it in this healthcare setting, but connectivity with each other. And that's the good and the bad of it, because it also is about connectivity with information. And then the question is, the other piece that came up in the conversation that you had with those people was one about preferences, as Sarah mentioned, and the preference to be in front of somebody versus dealing with somebody through a screen, and it feeling better or different. But sometimes when there's information just being given to you, and if you trust the source of that information, you may take that as actionable information that you're going to go do something with. If you don't trust the source of that information, then you won't. So the connectivity can also be to things that are not necessarily accurate, not necessarily true, maybe not true for you, and they may not be timely either. And so we've got this challenge with connectivity being a great thing, but connectivity also having this potential, as we've seen in a number of different non-health settings, to create opportunities for the spreading of misinformation and the spreading of information that actually does not allow people to make good decisions that are right for them and their families. And the speed with which that information can now get across the world is so much beyond, to Chris's point about beyond what we could have ever imagined. It's beyond what we could have ever imagined. We used to talk about pandemics back in 2003 was SARS-CoV-1 and say, okay, well, if a group from this particular part of the world comes to this part of the world and for a conference or whatever, then there'll be this likelihood of a spread because of air traffic. The number of people moving via airplane has exploded. I mean, obviously it went down during COVID, but exploded over the last 2 decades with people being able to take relatively cheap flights and spread tons and tons of things, communicable disease in this particular case, very, very easily. Similarly, with connectivity and technology, the ability for bad things to move around very quickly is at a very, very high level. So it's understandable that there was the trepidation and concern that was voiced by a few members of the people that you spoke to around their health information, but just information in general, and concerns about privacy and the preservation of that were also the things that sort of struck me from that conversation. But I thought it's interesting to sort of think about where we've come from, and the fact that I think we're also somewhat guilty of oftentimes engaging and thinking about solving for today versus solving for what's next. And what's next is stuff that people say, oh, that's Star Trek, that's Star Wars, that's over there. And then 5 years later, it's here, we're still around for it. We're like, oh, maybe we should have been paying attention to that what's next thing. That's a conversation we have a lot around Web3, right? And a lot around technologies like blockchain and AI. That was a movie back in the day. Now it's the reason why that pair of shoes follows you around your entire web existence. So I think that we need to be far more adventurous because what people are experiencing today is not what we need to be innovating for. We need to be innovating for what we're about to be experiencing and can imagine experiencing into the future, which is an important piece of another part that I got out of what some folks were saying in that conversation.
Yeah, can I add to that? I think that's an incredibly important point, and that's why even when we talk, so 2 issues. I don't think it's appropriate. It's wrong. It's not. We will not get to the solution we're all trying to get to if we don't involve patients more. Let's just start there, okay? We got to not just involve them once, iteratively, over and over and over again throughout the design and development process and going forward. Okay, so that's the baseline. However, we are also living, as Pierre mentioned, in a very time of transition, right? And you can look back at any time technology in any other sector was introduced, where you're talking about the car, the phone, the personal computer, the radio, the record player, all it's the same thing. I actually looked at it. So it happens every time that you actually can't go just on what people say, because when Ford made the car first, people would say, well, why do we need faster horses? You know, and they couldn't fathom it. And that's exactly what disruptive technology is. All these people running around talking about their products are disruptive technology. They don't know what they're talking about, because disruptive technology are technologies that usually are small, but have such great impact that the future of what it does can't even be envisioned. It can't by those people who are using it right now. And so, you know, it is about where is the future going, and none of us have a crystal ball, but, you know, the world and cycles tend to repeat themselves, so we can learn some things if we're willing to look other places, and that's one of the things healthcare typically doesn't do, and I think it's hurting them in this respect right now.
Yeah, absolutely. And I love that point too on, you know, we do need to enhance our understanding of what we think patients, consumers want and need, but it's not just taking that and operating within that status quo. I love that point about, you know, if it's going to be disruptive, if we're actually going to maybe bridge some of these gaps in the digital divide, it's about going, you know, multiple steps further to truly be disruptive. So I love that point. Sarah, I saw you nodding your head there as well. Anything to add from your perspective?
Well, I think this is really an important point about understanding where people are and what their preferences are. but they might not be able to say this is a solution. I think there's real work to creating that solution that you didn't know could be a solution, right? That maybe that's part of what you're mentioning, Chris. But it's really striking to hear people's concerns about privacy, about where their data are used, how will the data be used. So I don't think that should limit us from using technology, but it's a barrier that we have to think about. Well, how do we get over that, right? Yeah. And we've heard these concerns about. One of the challenges that we have with, and I know Pierre, you mentioned using algorithms and just the incredible opportunity to use algorithms to help us understand the wealth of data that we have. And we also need to be skeptical and wary about some of the quality of the data that are going in there. And that's something we're working on right now, is trying to understand how do we get better data about people's race and ethnicity and identity in terms of sexual orientation and gender, and also their disability, because we need good information that's going to help us use those algorithms, develop tools, but we also need to be working with people in a way that they feel that their worries and concerns are heard, and that they're addressed, and that we're on their side, rather than feeling like if I give this information, it could be used to harm me, because certainly there are a lot of people who have experienced harm in our healthcare system and in our country in general. So their skepticism is well deserved, and it's something as we embark on using technology, we need to be holding that in our hands as we work to address equity.
Alexis, can I just...
Go ahead, Pierre. No, go ahead.
Just very quickly to points that both of you made, actually, and Sarah, you just commented on this piece about privacy. How we ask the question, how we engage people in these conversations is critical. And Chris talked about the iterative and ongoing engagement of people, as opposed to what I have colleagues who I very much appreciate refer to. We should do a focus group, and it's a singular event, right? It's a single event. We should do a focus group. We'll go and we'll talk to them. We'll get some people together. We'll talk to them. We'll feed them, give them a gift card, something, and get all the knowledge that we ever want to get, so that we can go off and do this program design, project design, technology design, you name it. But it takes longer to listen. It takes longer to listen and to say, okay, we heard what you said. We're going to incorporate this into the design of our product, platform, project, etc. And we're going to come back and let you look at it, feel it, do what you have to do with it. And we're going to listen to you again. And we're going to do it over and over again. And then we get to understand, as I think you did, Eleanor, when you were talking to people to say things about things that inform us about their concerns. So if I ask somebody, would you make use of a privacy preserving piece of technology? If you're like, what? I don't know, what are you talking about? The answer to many people is, well, yes, of course I would, but what does that actually mean? Well, maybe that's something that we get to by asking and dealing with a set of products and generating that product with people, and come to find out that people are particularly concerned about privacy preservation and would use something in one way versus another way. So I think how we ask, whether or not we choose to listen, we have this issue in health services research all the time, where there's a strong penchant for quantitative methodologies, where we can just go look through the data, because that's all we're interested in, and the stories behind the data get lost because we didn't listen to people, and we didn't source that data from the edge, if you will, from the actual person. It came to us cleaned, washed, scrubbed, or quite dirty, but we still used it because it's in the data set and it's what's available to us. I'll be quiet, Chris. Go ahead.
I 100% agree, and I know we want to go to another question, but this is the last thing I'll say here is agreeing with both of you. There are so many things going in my head, but on this issue of sort of asking people the right questions. I've done focus groups and in-depth interviews with hundreds and hundreds and hundreds of low-income, inner-city, African-American seniors in Baltimore, D.C., Oakland, California, all over the place. And this was years ago, so I'm not even talking about right now. So this is even at the beginning of all this. I was fascinated, especially among the seniors, to give you an example, where Pierre's right. We talk about things as if people all understand and use the same language. When you would talk about things, they look blank. I go, what do you mean? They can't even conceptualize it. So the idea that we're asking and getting an answer, that's all we need to do, it's just not there. But to a specific point on privacy, I found it fascinating where a number of people, when you sign up, you get them to the point where they can understand what technology might do in some ways. Oh yeah, I would like that. These are seniors. A few wouldn't, but some would. And so this issue of privacy, and this particular example I'm giving you is among African American, low income, inner city. The issue of privacy and security did not come up. It just did not come up in our conversation. So I asked it. Right? Because I know that we think about it. Academics think everybody thinks about it. So I asked them. Yeah. And they said something that was really fascinating. And I heard this over and over again. They say, yeah, we have those concerns. But let's face it, if we don't do this, we know we're going to be left further behind. Right? So the issue of privacy and security is real. And but it is not the end all and be all that I've heard it, at least in some populations, that I've heard if you don't get that right, you can't do anything else. No, that's not what our research and the work that we have done has shown. And I found that to be quite fascinating on one side of the coin. So the only other thing is, so understanding, I think the other thing is, as Pierre was alluding to, is being able to interpret the data properly. And you got to have a broader context. One quick example, I was involved in some large studies many years ago at Hopkins, looking at disparities in diabetes, stroke really, and stroke outcomes. I was specifically asked to be a part of this project because the NIH totally goes, well, you don't have expertise in this area with underserved populations, the tech, so I got on the program. So they put this intervention together. First, people were confusing stroke with heart attack. That's one issue. But even in those who weren't confusing stroke, that the ideal treatment for stroke, once you have it, is to get to the emergency room as fast as possible because you have a limited amount of time to give a very specific, powerful medication. And about 30% of the African Americans who knew they were having a stroke or their family members were having a stroke still delayed to go to the emergency room because they first wanted to talk to a family member or a pastor or somebody else who was important to them. And when the study team found that out, they're like, oh man, we got to develop an educational intervention to teach these guys. They only got 3 minutes, to get to they got to get there. And I said, no, this is not an educational problem. This is a cultural problem. People in African American communities, it's not this rugged individualism like that we try to portray in this country a lot. They have a notion of what you think they need to do, but they want to see what the people that are important to them, which might be mom and dad, it might be the pastor, it might be somebody. You might not like that they do that, but that's what they do. And then on the combination of both things, that's what they make the decision. So if you try to force them out of that cultural norm into where you think they need to be, it's not going to work. It's not going to work well. And so I'll stop there, but
yeah, no, absolutely. Such good points. And Pierre, also what you mentioned made me think about, it's kind of this agile nature of the healthcare industry. We need to make it more iterative, but we also need to acknowledge faster when things aren't working. So if we're taking an approach or, opinion into things and we're seeing quickly in those iterative steps that things aren't working, being able to kind of move on faster so that we get to the solution that does work for individuals.
Yeah, I'm going to healthcare. And it's not just healthcare.
Yeah, so true.
This is a cross-sector infection. So yeah.
Yeah. So true. I was going to say, I'm going to pivot us to Ellie to get her kind of opinion on this and sort of her thoughts based on what she heard from individuals. But while she's doing that, I know we've got about 8 to 10 minutes left. So when we come back, I want to go round robin and I want to make this super tangible. If you were to give input or advice to the industry right now, what's something that you think the industry should stop doing, should start doing, and continue doing to drive forward with equity? But I'll give you, in tech equity in particular, so I'll give you a minute to think about that as Ellie's kind of giving us her reflections.
Cool, thank you. Yes, I'm so often reminded of the phrase, you can take a horse to water, but you can't make it drink. And obviously, this is my job, and I'm just so happy to hear you all talk about the importance of doing research with people and listening to them, and not just kind of asking them questions on the nose, but when we do our ethnographic research, we're looking out for people's behaviors, people's workarounds, the funny little ways they kind of come up with to work around a problem that they're dealing with, and also I think understanding why it is that people might not want to interact with technology and what those privacy concerns are. And we see things, like when people have had experience of fraud, for instance, or, people don't see themselves as being particularly technological and they'd rather just speak to someone face to face. And so I think, when we listen to people and when we kind of, walk a mile in their shoes, so to speak, you can really understand what's going on a sort of demand side, and then that can pave the way for better design, for interventions and offerings that actually, as we say, meet people where they are and meet those needs that people aren't necessarily able to articulate in a kind of question and answer format, but they can sort of show you with their behavior and what they're doing in their daily lives. So, yeah.
Yeah, thank you, Ellie, so much. And I know we've got about 5 minutes left, and so I know it's hard to condense some of these. I know I give you a big ask for a short time, but maybe Chris, I'll go to you first. What should the industry start, stop, and continue doing?
Sure. Maybe two things I'll say. One is a little humility here. Understand that even though we've been fortunate, we've been trained, we're the experts. We don't know everything, and we need to realize that and really talk to people, listen more to people, and then do something. It's kind of measure twice, cut once. And the other thing is, really involving people and recognize the ways that we act are really off-putting to people. The language that we use, the terminology that we use, we call patients who believe in God as that, oh, that's fatalistic. You're putting me down for my faith that I have. So many examples of that, but I'd say those two things would be a great start.
Wonderful. Sarah, how about you next?
Chris has it. It's listen. And I think it's that intentional listening that starts and builds a relationship of trust and understanding that that the organizations developing and deploying technology are really trying to help, not try to just save money, not try to create a second class kind of care, but really trying to build the trust, and that comes from the time you spend listening and the authenticity of the listening. And so just double down on Chris's listen guidance.
All right. Pierre, what do you think?
All right, I'm going to try to make this quick. Start embracing user input in this ongoing manner into the design and creation of your programs, whatever they may be. Also start investing in not just cross-sector things, so investing in affordable housing is nice, investing in transportation is nice, but start investing in those sectors to build them up so that they can actually share the accountability with you in the health sector for outcomes. It shouldn't just be the health sector that looks to take care of, healthcare sector looks to take care of health. Stop spreading health equity around like confetti. It is not. Health equity is something that is, it's a goal, and it has a particular set of things that we're trying to achieve: improving access, removing barriers to access, providing scaffolding. But this confetti business needs to stop, because I see very few systems also providing the vacuum cleaner for cleaning up the confetti after the party's over. So stop spreading it like confetti. And continue to be engaged in the social determinant of health work, but work with your partners who do that work most effectively. Healthcare doesn't need to become all the things it's trying to become outside of the clinical space. I applaud healthcare for trying to do these things, but it is outside of our lane. So continue to see the value in partnering, and continue to innovate in that space by looking to partner with those who are outside, who do that work far more effectively, because it's what they do. They don't come, housing sector doesn't come in and try to do surgery. We shouldn't be trying to necessarily go out there and do their work.
So well said. I'm looking at the time here. We've got 2 minutes left. Any final closing comments or thoughts from the panel members? And I want to thank you so much again for joining us. It's been a wonderful conversation.
Yeah, I think it's exciting times. And like I said in the beginning, the world, not just any one individual, the world has not been successful in dealing with this before for some very difficult reasons. But I personally think for the first time, we have the opportunity, the real opportunity of closing and eliminating some or all of these gaps. We're going to have to rely on more on technology, but for the first time in the history of mankind, we can get there if we want to.
I think if systems take your 3 access, adoption, and sustained use bullets and use those in everything that they're doing, so don't just put something out there because it's going to be quick in the fire and then out and done. Those 3 bullets, I think, are priceless, and I think that they don't just have relevance to the technology piece of things, they have relevance across sectors and in the way that we engage.
And I think that long-term commitment is what we should be measuring and what we need to incentivize. And so the concern we have is that the incentives don't always get us to the same place in terms of how payment is provided in our healthcare system, how resources are shared, even as we're looking at healthcare organizations take on more of a role in social risk or social determinants, just because the money might be, just because that might be in the interest of the healthcare organizations doesn't mean that they get to drive it and they should have all the power. So really be thoughtful about how to share the power and share the learning and the knowledge to support individuals and communities.
Love that. Thank you all so much. Really appreciate your time. And I think with that, Ellen, we're ready to close. Thank you all again. Enjoy the rest of your day.
Thank you.
Thank you.
I just would really like to thank our co-hosts, Alexis and Ellie, and also to our wonderful guests for today's really dynamic, interesting discussion. Thank you, everyone who joined us and stayed with us. If we didn't get to your question, we will reply by email. And remember, by email, you will also receive a link to this recording, quite likely not till Monday, however. There is the handout in the control panel that I want to remind you to download. And of course, at any time, we welcome the opportunity to speak with you directly, so please feel free to reach out. That now concludes today's webinar. Have a wonderful Friday and weekend, everyone.
Bye all, thanks again.
Take care, thank you.